Welcome to 2-Minute Anaesthesia in Critical Care. Today we're going to discuss amniotic fluid embolism. AFE was first described in 1926. It's defined as a life-threatening condition mediated by cytokine release secondary to exposure of amniotic fluid antigens during the peripartum period, most commonly during labour, 70%, or delivery. The incidence is largely unknown, but is thought to be between 1 in 8,000 to 1 in 80,000 per pregnancy. The pathophysiology. So there's a uterine injury leading to amniotic fluid within the circulation. This results in a humoral and immunological activation leading to a surge response and thus respiratory, cardiovascular and hematological compromise. AFE is associated with an acute PA obstruction leading to an elevation of pulmonary artery pressure. This leads to reduced flow to the left side of the heart and also an increase in back pressure in the right side of the heart. The right ventricle is relatively thin and therefore compression of the right ventricle leads to reduced myocardial perfusion and therefore ischemia. This can result in arrhythmias leading to cardiovascular instability and also in the more severe instances lead to cardiovascular collapse. In addition to this, you get activation of factor 7 and platelets leading to the activation of the coagulation cascade leading to DIC. DIC is a consumption coagulopathy, so you get consumption of all the clotting factors and therefore thrombosis, and once they're used up, bleeding. Diagnosis with reference to clinical features. Most commonly occurs during the peripartum period, leading to sudden collapse of the cardiovascular, respiratory and neurological systems. Cardiovascular, this can result in tachycardia, arrhythmias, hypotension and collapse. Respiratory, tachypnea, hypoxia. And neurological, which could be mild dizziness all the way to seizures and low conscious level, followed by DIC. This could be micro or macrovascular thrombosis in addition to bleeding. Risk factors include caesarean delivery, instrumental delivery, placental pathologies and preeclampsia. It's important to exclude other differentials. These include classic differentials for PE, anaphylactic shock, septic shock, but more obstetric related leading to cardiogenic shock, air embolus, for example from a central line, or major hemorrhage which is unnoticed. The following are A's used as a mnemonic devised by the American Heart Association to remember the causes of cardiac arrest in a pregnant woman. A for anaesthetic complications, for example a high spinal. B for bleeding. C for cardiac, for example peripartum cardiomyopathy. D for drugs, excessive oxytocin. E for embolus. F for fever. J for general. So hypoxia, severe hypoxia can lead to these signs and symptoms, in addition to electrolyte disturbance and, for example, hypertension. So the criteria for diagnosis include no fever during the labour, the onset during labour or within 30 minutes of placental delivery, and sudden onset cardiorespiratory arrest or compromise with a blood pressure less than 90 systolic, and overt DIC by the International Society of Thrombosis and Hemostasis diagnostic criteria. These criteria are defined by a reduction in platelets, an elevation in PT, an increase in D-dimer, and a reduction in fibrinogen. Now let's discuss investigations. Basic observations should be done. As mentioned, the patient could be tachycardic, hypertensive, tachypnic. An ABG may show type 1 respiratory failure, in addition to possibly anemia, a high lactate, and a negative base excess. And finally, an ECG. Bloods should show a full blood count to assess platelets, hemoglobin, white cell count, and also markers of end organ damage with reference to using these LFTs. The coagulation, as mentioned, may be abnormal, and also the bone profile may show a reduction in calcium. Other markers of end organ damage may be a troponin or BMP. Important imaging may be a bedside echo, in addition to an abdominal ultrasound if the diagnosis is unclear, and a chest x-ray. Based on the patient's clinical criteria, you may suggest a CTPA based on stability. Now let's discuss management. So the management should either be an ABCD approach versus an ALS approach in the arrested patient. If the child hasn't been delivered, they should be delivered and therefore transferred to ICU for post-op care. The patient most likely will be intubated and may require optimization of ventilation with PEEP, lung protective ventilation strategies, i.e. ratio manipulation, all the way up to paralysis and ECMO. Cardiovascular, a good assessment of volume status in addition to an echo to guide fluids, inotropic and vasopressor support. Adequate sedation, temperature control and management of DIC is essential under haematology. Prognostication of these patients is difficult, however the mortality is 50% in the first hour from profound hypoxia. Cardiogenic shock and arrest accounts for 80% of cases and the mortality is up to 90%, and those who survive have an 80% chance of having a hypoxic brain injury. Once again, thank you for listening.